stasis disease, hypertension, the entire body is affected. And so when we look at the treatment of obesity, really want to realize that we want to change the paradigm of treating separate problems to addressing the underlying cause of these medical problems. And so diabetes is just one of those causes. And so we also know that that therapeutic weight loss reduces the complications of obesity, and we can adjust the amount of weight loss to target the particular complication. And so there are different percentages of weight loss that are required for therapeutic benefit. But when it comes to diabetes and hyperglycemia, we definitely have specific numbers. So for diabetes prevention, the amount of weight loss to achieve a benefit is somewhere between 3 and 10%. And you get the maximum benefit for diabetes prevention at about 10%. But when it comes to treating hyperglycemia, the weight loss benefit is basically unlimited. And so you start to see a benefit at 3%, but even going to 10 and 15%, you get continued benefits on diabetes and hyperglycemia management where the A1C continues to decline. And as you can see from this slide, each individual complication has its own amount of weight loss that's required for therapeutic benefit. But some of them are less, some of them are more. When it comes to things like sleep apnea or metabolic associated dysfunction associated steatotic liver disease, you need at least 10%. But for other conditions like hypertension and dyslipidemia, smaller amounts of weight loss will produce a benefit. Now, this is from the American Diabetes Association standards of care and management of diabetes and the use of glucose lowering medications. And the point I want to emphasize, I have circled in red, and I just want to, this is a blow up of that section, but this discusses the achievement and maintenance of weight management goals for patients with diabetes. And so the American Diabetes Association recommends setting individualized weight management goals to give general nutrition and lifestyle advice, eating patterns, physical activity, and then to consider medications for weight loss, or more specifically, to consider medications to treat diabetes that also have high efficacy for weight loss. And so the American Diabetes Association recommends semaglutide and tirzepatide as those that have the highest efficacy. And so those would be a good choice when you're selecting treatments based on complications. Now, this is a similar approach. This is from the American Association of Clinical Endocrinology, and this is our diabetes algorithm. And you can see that we have this is from the glucose-centric algorithm for glycemic control, and you can select your treatments based on the individualized target. So ACE recommends for patients with overweight or obesity to have GLP-1 receptor agonist or a dual GIP, GLP-1 receptor agonist as the first choice for glycemic control because of that added benefit of weight management. So when it comes to weight management, even as a diabetologist or an endocrinologist, we always want to consider all medications that could be an advantage to our patients. And so this is just a list of the first generation anti-obesity medications where you're getting weight loss on the range of somewhere between 5 and 10%. And these medications have been very effective and very helpful. But what we're really happy about is now that we have the second generation medications, such as semaglutide and tirzepatide. And so these medications are giving much greater levels of weight loss on the range of 15 to 20%, sometimes even more. And so it's really changed the paradigm as far as having the availability of medications, much more powerful medications that are effective for weight loss. And this is an interesting study looking at weight loss in individual anti-obesity medications in both humans and rodents, but it's comparing on the left, you see the diet and exercises at the very top in blue, a small amount of weight loss, and then the different types of medications. So the smaller amounts of weight loss, the first generation in brown is naltrexone, bupropion, and pink is phentermine, topiramate. But then you start seeing the second generation medications giving this greater amount of weight loss, semaglutide, the 1 milligram dose, and even more weight loss with a 2 milligram dose. And then you see the weight loss very similar on this slide with tirzepatide, 5 to 15 milligrams. And then we have bariatric surgery, which is at the very bottom in red, showing the greatest amounts of weight loss in this study. And this is a little bit more recent published data. This was from a phase 3 open label randomized trial. It was called Surmount 5. And it was a direct comparison of semaglutide versus tirzepatide. And this particular slide is looking at the mean change in body weight at 1 year. And you can see semaglutide is in the dark blue and tirzepatide is in the light blue. And you can see changes in body weight for all groups. And then it's divided out into those with type 2 diabetes and without type 2 diabetes. And you can see that there was a significantly greater weight loss in the tirzepatide group compared to the semaglutide group. And this is from also from the Surmount 5 study showing the categorical weight loss for tirzepatide versus semaglutide in the weight loss categories of greater than 5% weight loss, 10%, and 15% weight loss. And you can see that in each of these categorical weight loss categories, tirzepatide had greater weight loss compared to semaglutide. So I think that at this point, we've demonstrated that the GLP-1 based medications are very effective for weight loss, for treating diabetes and hyperglycemia. But we also have to think about the potential side effects of the GLP-1 receptor agonists. And so this slide summarizes those that are known adverse events, possible adverse events, and doubtful adverse events. Nausea, diarrhea, constipation, and vomiting, by far the most common. These are more common in the first 4 weeks or 4 weeks after a dose is increased, and then tend to subside with time. But other considerations are reduced bowel motility, possibly ileus, retained gastric contents, and gallbladder disease. Also, if there's severe nausea, vomiting, dehydration, there can be acute kidney injury. The ones that are just possible adverse effects are sarcopenia and neuropsychiatric events. And then we're kind of doubtful about retinopathy, medullary thyroid cancer, and pancreatitis or pancreatic cancer. But we know now that the GLP-1 medications have tremendous benefit, not just from diabetes and weight loss, but we're seeing improvement in major adverse cardiac events, in HFpEF and heart failure and kidney disease, and then potential benefits in metabolic liver disease and in neurologic diseases and peripheral artery disease, stroke. And so these medications really are treating the entire metabolic system and benefits on multiple complications. So finally, I just wanted to finish up with looking at the future. And this is a slide looking at the weight change for current and future GLP-1 based medications. We have the single agonist, the dual agonists like tirzepatide, and you can see the one that's giving us the most weight loss on this slide is a triple agonist. But there's multiple medications in development right now, so the future is very exciting. And so I want to thank you for this brief